No, it's fine, it's fine, it's fine.
Okay.
A very good afternoon and welcome to the session on the topic postmenopausal bleeding. We are glad to have Dr. Chandana Galidevira among us today to help us understand the topic. The doctor will take us through the session more in detail. So if you have any questions, any doubt, post that on the comment section. That the doctor will take up your questions at the last of the session. Stay tuned till the last and don't miss out on any important details for the topic. You have the stage, doctor.
Thank you very much for that introduction. I'm Dr. Chandana, obstetrician and gynecologist. Today I'm going to give you an overview about postmenopausal bleeding, what are its causes, how do we evaluate, and a short summary about how we go about with the treatment. Now, coming to postmenopausal bleeding, according to definition, it means bleeding from the vaginal tract anytime after cessation of menses for at least an year. So 1 year of stoppage of menses, we call it as menopause. Menopause is a retrospective diagnosis. The average age of menopause is around 51 years. So it can be earlier for some women, it can be late for some women. But once the menopause is attained, usually we do not expect women to bleed after the menopause is reached. So, whenever there is some bleeding from the genital tract after the menopause, it is always a cause for concern. And this is a very, very important topic for the women's health, especially for women who are in their mid 40s and beyond. So, coming to the causes, why are we so concerned about postmenopausal bleeding? It is because in 10% of the women, it can be because of any sinister cause or it can be pointed towards cancer. So, most of the time, 90% of the time, it is a benign cause, nothing which you need to be too concerned about. But then 10% it can be leading to a more serious diagnosis. So, which woman is having cancer and which woman's cause is a benign is something we need to evaluate and find out. And until we find it out, we cannot rest. That is why, whenever a woman has postmenopausal bleeding, it is always considered as a serious concern and it definitely has to be evaluated. And also, cancers are more common in the age group after mid 40s. So it is another one reason why you need to be all the more on a high alert situation and get yourself tested and evaluated. So coming to the causes, like I said, the benign causes first. So most of the time it may be because of thinning of the vaginal lining or some kind of inflammation or infection in the local area like the cervix or the neck of the womb or the vagina. During menopause, women undergo a lot of hormonal changes, and sometimes the hormones are actually on the lower side. So the estrogen is no longer there the way it is there in the reproductive age group. So what happens? The vaginal health is may not be very good, and the lining may start becoming more and more thin. This will predispose to bleeding per se, which can be spontaneous or even a small trauma or trigger can predispose to bleeding from the vagina. So that's one of the commonest reasons why women bleed after menopause. Most of the time, it may be just a vaginal thinning or some kind of inflammation going there. The other reason can be some kind of infection in that local area, either in the vagina or slightly higher up in the neck of the womb or the cervix. So, infection in this area, it can be a fungal infection or a bacterial infection, or it can be a sexually transmitted disease. This can also predispose to bleeding from that area. Apart from this, there are certain growths called polyps. So polyps are nothing but these are non-cancerous growths. They are like outgrowths from the inner lining or from the neck of the womb. So we have both cervical polyps, which are in the outside, and also polyps inside the lining of the uterus. So these are called as endometrial polyps. So these are actually non-cancerous growths, but they do cause bleeding from the genital tract. So these are some of the common causes. One more important reason is women who are on hormone replacement therapy. So some women might attain menopause a little bit earlier, and they might be actually going through a lot of difficult symptoms like hot flushes or mood swings. And because their menopause has happened earlier, doctors might have prescribed a hormone replacement therapy. They might be using some hormones. So whenever they are put back on hormones, that can also activate the inner lining to grow, and then they can have bleeding from that. So always it's important to take a medical and drug history from the patient, whether they are using any hormones when we are evaluating for postmenopausal bleeding. So these are the most common benign causes. Coming to the malignant or the more sinister or serious concerns, what we are worried about is cancer from the cervix or the neck of the womb, and cancer of the uterus, uterine lining basically, which is technically called as endometrium. So endometrial cancer is one of the commonest causes for postmenopausal bleeding, and also the cervical cancer. Apart from frank cancer, there can also be precancerous conditions, like there may be just thickening of the inner lining of the uterus. These are called as hyperplasias. So hyperplasia means overgrowth of the inner lining. The name itself means that it's just a overgrowth of the inner lining. But sometimes in this overgrowth, the cells may not be normal cells. They may be abnormal, and they can be precursors to cancer. So probably if left undetected and untreated, this kind of women might develop frank cancer over a period of years. So, endometrial hyperplasias, endometrial cancer or uterine lining cancer, and cervical cancer or the neck of the womb cancer. These are the most common causes for postmenopausal bleeding when we are looking at malignant causes. Sometimes, in very rare cases, even ovarian tumors or ovarian cancer can produce postmenopausal bleeding. So, some kind of ovarian tumors tend to produce hormones. So whenever there is hormonal activity going on, that can again stimulate indirectly the inner lining to grow, and then the inner lining can shed and present as a postmenopausal bleeding. So these are the uh, cancerous conditions we need to rule out whenever we are evaluating a woman for postmenopausal bleeding. And coming to the evaluation, so whenever somebody comes to us with postmenopausal bleeding, we take a quick history. We ask them like how much of a bleeding they had. Is it a light spotting or is it heavy bleeding? Because when we are talking about uterine cancer, usually the bleeding may be slightly in excess, because the inner lining may be overgrowing. So sometimes when they start bleeding, they can bleed in excess, or they can even have clots. So the quantity of bleeding matters, because the more they bleed, the more they are at risk for anemia. So whether they have any anemia symptoms, do they have, if they have been bleeding for a long time and they haven't realized, they have presented very late, then some of them can present with anemia as well. Symptoms of anemia like fatigue, generalized feeling of being unwell, and sometimes having a fast heartbeat. So these are some of the symptoms of anemia. So we ask them for all this history, and any other symptoms like concomitant symptoms, any kind of tummy distension, whether they are having any swelling anywhere, whether they are having any bone pains, and other symptoms. Then we go about evaluating. So when we are evaluating, we do a general physical examination. This is the most important thing before even we proceed to investigation, because if it is a benign cause or a cause which is external, it can be easily detected by just a examination of the vagina and the cervix. So there is a speculum examination. All we need to do is put a light and a small speculum and look at the vagina, whether there is any thinning, is there any trauma, is there any tear which is bleeding, or any outgrowth from the cervix, or any inflammation in that area. So if we find any of this, the diagnosis is pretty straightforward. but still we need to make sure that we are not dealing with any of the cancerous causes. So even though we know the diagnosis, it is always better that we still evaluate them further, offer them a cancer screening, definitely in the form of pap smear and ultrasound. I'll come to that a little later. So once you do a general examination, we will be able to find out the local causes, any issue in the vagina or any problem in the neck of the womb. But anything beyond that inside the uterus or any problem in the ovary needs to be detected only with a scan or the ultrasound. So after the physical examination, we would offer them a pap smear. So pap smear is a test which is a screening tool for detecting cervical cancer. Cervical cancer can be detected in the early stages if we offer them a pap smear. If there is a frank tumor already, if there is a mass or a growth coming out of the cervix, then it is very clear that there is some problem. There is a cancerous growth there. In that case, there is no point doing a pap smear. In that time, we need to take a tissue test. We need to take a bit of the tissue and then send it for examination under the microscope. So this is called taking a biopsy. So we take a biopsy if we find any obvious or a frank mass or a growth coming out or replacing the cervix. But in case the cervix appears absolutely normal to the visible eyes, I mean it is just to the naked eye examination, it looks absolutely normal, then we need to do a pap smear definitely, because any early cancer or any changes in the cells or any precursor of cervical cancers can be picked up at this stage. So in pap smear, we have two kinds of pap smear. One is the traditional or the conventional pap smear, and the other is the liquid-based cytology. So whichever is available, depending on the place infrastructure, pap smear has to be done. So coming to a routine pap smear, we take some cells from the ectocervix and the endocervix. So these are areas of the neck of the womb. So endocervix is the part which is going inside, and ectocervix is the outer part which is visible. So we take the cells from that area with a spatula, and then we put it in a slide and then fix it. Coming to liquid based cytology, we have a cyto brush. It's easier. All we need to do is take the brush and then rotate it 360 degrees at the cervix, and then we put that in special containers and then send it for examination. So pap smear has to be done every 3 years for women after at least they are crossing 30 and beyond. It has to be offered every 3 years. And pap smear can detect any kind of abnormal cells coming from the cervix, any precursors. And sometimes, if we find any cancerous cells or precursors, we need to go ahead and do other procedures to detect what exactly is wrong in that area. We might be offering you a biopsy or a colposcopic guided biopsy. So these are advanced tests once there is some abnormality detected in the pap smear. Now, coming to the next investigation, which is very, very important when we are dealing with postmenopausal bleeding, is the ultrasound. So, ultrasound or scan, preferably done in the vaginal route. Although abdominal ultrasound can be done if there is no other way, or we do not have the expertise or the probe which can do it vaginally. Vaginal ultrasound is the most sensitive form of investigation to detect any problem inside the uterine lining. So we offer a transvaginal ultrasound, and here what we look for is the inner lining thickness. So generally in a postmenopausal woman, we do not expect the inner lining to grow like a normal woman, and then we do not expect it to shed every month. So whenever there is a overgrowth of the lining, where the cutoff is usually 5 millimeter, some sources give it as 4 millimeter. So in general, any endometrial lining thickness more than 4 millimeter, it definitely needs further evaluation to see why it has occurred in the first place. Because after somebody attains menopause, their hormones are going to be very low, and their uterus is not going to function anymore. But imagine if the inner lining starts overgrowing, then there is some other sinister activity going on which needs to be evaluated whether something is really wrong or not. So the commonest reason why this inner lining can become thick can be endometrial hyperplasia, which is a precursor to uterine cancer, or it can be a frank endometrial cancer per se. And in rare causes, it can be just a hormonal activity also. But until and unless we know what is happening inside, until we see the cells and see that they are really not cancerous cells, we cannot rest. So we do a transvaginal ultrasound, and if the thickness is less than 4 millimeter, and we find any obvious local causes like vaginal thinning or the cervix having inflammation, there ends the evaluation. We just have to treat them for the local causes. But in case we find that the inner lining is growing beyond what is expected, then we definitely need to go ahead and do a testing of the inner lining. So testing of the inner lining is called as, again, endometrial biopsy. So biopsy is nothing but taking a tissue or a sample from whichever targeted area. So when we say endometrial biopsy, it means we are taking a biopsy from the inner lining of the uterus, which is technically called as endometrium. So endometrial biopsy. And sometimes apart from biopsy, we have other options. We can go ahead and do a full dilatation in curettage. So in curettage, we scrape all the walls of the uterus, all the four walls, the anterior wall, the back wall, or the posterior wall, the side walls, and we send all the tissue material which we get when we have scraped it. So that is a complete dilatation and curettage procedure. But instead of that, we can also do a endometrial biopsy where we use a very thin straw-like catheter. We insert that inside the neck of the womb, and it will reach the inner lining. And from there, due to suction activity, we can just get a tissue bit. And that tissue bit will be sent to the lab for further studying to see if there are any abnormal cells detected or not. So that's about endometrial biopsy. In certain cases, if still the diagnosis is not very clear, either the biopsy comes equivocal or we do not get enough tissue sample, there is another option called as hysteroscopic guided biopsy. So this is a slightly elaborate procedure. So what does hysteroscopy mean is, it is nothing but a long tube with a camera. So like how we do laparoscopy, where we put a tube inside the tummy through the belly button and look at all the organs inside the abdominal cavity. Similar way, we have a tube which can be put into the inner lining of the uterus, which can be put into the uterine cavity, and you can visualize the internal aspect of the uterus. We will not be able to see anything what is outside the uterus, but whatever is inside the uterus, the walls, the upper part, the roof, the front wall, the back wall, the side walls, everything can be visualized using a hysteroscope, and it is done from below. And when we do a hysteroscope and when we are evaluating the walls of the uterus, we find any suspicious growth, or we are seeing any abnormal growth in that area, we need to take a biopsy or a sample of that area. So this is a more targeted procedure where we can exactly see what is going on inside the uterine lining. And if we find any suspicious areas, those areas are selectively taken and they are biopsied and they are sent for further studies to see if there is any abnormality. So sometimes the report can turn out to be just benign polyps. So the polyps are nothing but overgrowth in the inner lining. So if it comes out as polyps, then we can just treat them. The cutting, I mean, the removal of polyps itself is a treatment, or sometimes you can give them hormones. But if it comes out to be cancerous cells, then we need to make a treatment plan to stage the cancer and then grade the cancer and then make a elaborate treatment plan depending on the staging and grading of the cancer, whether it is stage 1, we need to just operate, or we need to give them further radiation or chemotherapy, so on and so forth. So I will not go into details of cancer treatment, but what I would like to confine myself to is that once we do a hysteroscopic guided biopsy, we can have the report in two ways. We can either get them as just an overgrowth or polyp or something like that, or we can even get a malignant report or a cancer report. So depending on what the cause is, the treatment will have to be planned. That's about the investigations. How do we treat it? So treatment, I have covered a little bit of the treatment when I was talking about the investigations itself. So treatment mainly depends on the cause. So if it is because of an infection, we need to give antibiotics to subside the infection. If it is because of any kind of vaginal thinning, that is mainly because there are less hormones in the body. So what we do is we give those women estrogen creams. The vagina has become very thin, and that's why it is susceptible to trauma, and it keeps on bleeding whenever the patient has sexual activity, or there is some kind of minor trauma there. So what we need to do is give them estrogen creams so that the vagina can regenerate, and the vaginal epithelium can regenerate and remain supple. And so that is one form of treating the vaginal thinning. Other ways, you can put them on a full-fledged hormone replacement therapy if they have other concomitant symptoms. Along with vaginal thinning, they have hot flashes, or they are having a lot of bone loss. You want to go ahead and put them on hormone replacement therapy. That depends on the individual patient's problems, and that needs to be discussed with the doctor and then make a treatment plan regarding that. So that's about how to treat the local causes. If it is polyps, all we need to do is remove the polyps. So polypectomy can be done. If the polyps are from the cervix, we can just do the polypectomy along with the diagnostic. When we are doing the examination in a minor OT, we can just remove the polyps. If the polyps are inside the inner lining, then if we are doing a hysteroscopy, we can remove the polyps along during the procedure. We can just plan the polypectomy as well. But if the diagnosis turns out to be a sinister cause or a malignant cause, then the treatment planning will entirely depend on the staging and grading of what cancer it is and what stage it is. So, like I said, if it is a early stage, the prognosis is better, and the survivability of the patient also is better. Survival rates are better. But generally, cancer treatment plan is never just the gynecologist alone can't decide. It always needs a multidisciplinary treatment plan. There need to be other specialists, because if it is beyond a certain stage, it definitely needs radiation. It needs medical oncologist in case a chemotherapy is involved, and it also needs a psychological counselor. It needs a lot of support and all those things. So generally, once it is going in that direction, then it becomes a multidisciplinary treatment. Although your primary doctor will be one person, and if it needs operation, it can be done by an oncologist, but you also need a team to support and then plan the treatment according to whatever stage it is. So that's about the cancer treatment in brief. So, coming to postmenopausal bleeding, to summarize, I would like to say that it is a serious concern which needs to be evaluated. Once it is evaluated and you find that the cause is benign, you can relax. But as long as the more serious causes are not ruled out, until and unless cancer is not ruled out, it is always better that you get further tested. Always get a pap smear done, get a ultrasound done, transvaginal ultrasound preferably, and if anything abnormal is there, we need to plan for a biopsy as well. And then, depending upon the results, we need to chart out the treatment plan. Thank you. So that concludes my session on postmenopausal bleeding, and I'm open to take questions. Thank you then.